So we welcome Dr. Tanmoy Biswas. He has worked at Shankar Netralaya, Kolkata as a consultant in the Department of Pediatric Ophthalmology and Neuroophthalm. He has been trained in Shankar Netralaya, Chennai and Kolkata. He's an expert cataract surgeon, both pediatric and adult. He has performed all sorts of complicated surgeries, including complex squint surgeries. He has keen interest in teaching, trained many fellows postgraduate during his time at Shankar Netralaya, and presented many papers and instruction courses at national and state conferences. We welcome you, Dr. Tanmoy. So a look at his case.
Started. Much started.
A 59-year-old male. So Tanmoy will be operating the left eye. The plan is for Phaco with PCIL under topical anesthesia. The grade of cataract is NS grade 2. Here's a look at the slit lamp photograph. And fundus examination and OCT, all within normal limit. Specular counts are good. And the biometry has been done by RL Master.
Okay, shall we start? Tanmoy, would you start? Yes, thank you. So switch over to Dr. Tanmoy, please.
So we have a long eye here. It's a 27 millimeter axial length, and the IOL power is 13 diopters. So if you could give us pointers on how to go about choosing and setting the parameters for these long eyes.
Right. So I think let's go ahead, and as Tanmoy goes one step at a time. So we'll take that question a little later, Soham.
Yes, sir.
So let's take about the trypan blue, the injection of a trypan blue. So trypan blue is something that has become quite a favorite for most of the surgeons, though it's not required for every case because you have a brilliant glow and one can do off a rhexis very well. But it definitely gives an edge of the accuracy of the rhexis. So it's worthwhile spending the 1 or 2 minutes to stain the anterior capsule with trypan blue. So with the trypan blue, the wash is also important, and if you are not able to wash it out well, does not really matter. Once in a while there can be a situation where, especially in subluxated or where there's zonular dialysis, that the trypan blue can migrate to the posterior chamber and into the vitreous, and that can stain the vitreous. So these are situations where one has to be very, very careful about this. So here we have the now let's take your question about the long eye and the parameters I think that have been set for the long eye. The intraocular pressure, and especially this machine, the Centurion, definitely needs a special mention because of the intraocular pressure settings that they have, and that can be set to a particular limit. At one point of time, we used to set up a tall bottle height, and with that tall bottle height, it would become very, very easy for one to do off all the steps of the rhexis as well as the nucleus management also of the the IA. But as we have believed that gradually it's more important to maintain a good intraocular pressure and a consistent intraocular pressure. So for any surgeon, maintaining this intraocular pressure is important, and this particular machine gives us the benefit of that. Gradually the pressure modulation can come down to from 50s, it can be made to 40s and 30s. So that depends again on the comfort of the surgeon, and as of now the intraocular pressure has been kept to 55, and that is something that is fine. However, if you feel that you can work at lower intraocular pressures, that benefit also can be given. So, and we know for a longish eye, a high myope, the possibility of the whole nucleus bag going down a little and making things a little more difficult for the nucleus management is of course there. Again, the pressure of the whole anterior chamber, which gets transmitted for the patient, and the patient might feel a little bit of discomfort, is another thing that has to be taken into account. And if the patient is not comfortable, then a little bit of intracameral anesthetic can be given as well. So usually this is the point where the AC deepens and that pressure sensation is there for the surgeon.
So last time we saw a direct chop, so now we are seeing probably a stop and chop.
Yes, Tanmoy is doing a stop and chop, and that's again a very, very comfortable situation. Dominic, you can also join me here.
So we have
So
in panel.
Tanmoy is doing a stop and chop, and the groove that he has carved is quite an adequate groove, and it gives a big benefit for the surgeon to hold the next piece right as close as possible to the posterior pole. So that's a big benefit that is there, and the benefit of holding the nucleus and then dividing it is there. Again, look at the way that the nucleus is being managed, and the excellent fallibility that is there with this particular machine. And it is really a big benefit, especially to our younger surgeons, to get the benefit of these machines where the learning curve becomes much easier, much faster than when you work on a machine with parameters where you cannot modulate to your liking.
Parthoda, good afternoon. Love here.
Ah, Love. Welcome, Love. Welcome.
Again, something very important for long eyes, what was done right now, to inject some viscoelastic before taking out the Phaco probe. Basically.
Are we audible, sir?
So Dr. Love again in our panel, he's one of the most experienced surgeons in this part of the world. And Love, thanks a lot for being here as not only a panelist but also one of our stalwarts to operate.
Thank you. Sagar is also there. Sudipto has come.
We would have loved to provide you with an opportunity to do a pediatric cataract. We'll take it to that for the next live surgery session.
Sure.
And
So we have been joined by Love sir, Sagar sir and Sudipto sir.
okay. So Dr. Sagar, welcome Sagar.
Good afternoon, sir. Thank you. Thank you for having us here.
Yeah.
Yeah.
Good afternoon, sir. Shudipto here, sir. Thank you so much.
So Shudipto, Dr. Surendra Prakash is all ready and set in the other OT.
Okay.
So, so you have to gear up, and you have to see the beauty of vitreoretina surgery being done by Dr. Surendra Prakash.
Sure, sir.
So get geared up, and till then, of course, and we can see Tanmoy is doing a nice polishing, and the benefit of polishing is definitely there. And So, Sagar, would you like to polish every posterior capsule in your surgeries?
No. Unless I see visible cells there or fine fibers there, I usually don't venture in polishing, especially if it's a high myope, because there is no vitreous support there, so very high risk of PCR if you're not polishing it. I mean, inadvertent PCR is very high. So not in every patient. But if there are visible fibers there, visible PC cells, it should be polished.
Absolutely. And what about Love? Love, would you do the same?
What I do, I wash the posterior capsule with a stream of saline for every case. And I use cap vac only when it is sticky and is not going with the saline.
Right. So now that we have these high-end microscopes, which are excellent to be used, which give excellent visibility, but at times I do think they are very uncomfortable microscopes. Why uncomfortable? You are seeing much too much. You are seeing too many things. You are seeing those little fibers that do not require any bit of polishing, which comfortably we were there in our previous microscope settings. So, so this is, I think, one of the biggest problems with these very, very good microscopes. And Tanmoy, what do you think?
Yes, sir. Right now we can leave those small, tiny fibers, but...
And I think this is Tanmoy's first live surgery, so congratulations, Tanmoy, for this. Very well done.
Yeah, absolutely. So, Tanmoy, thanks a lot. A big round of applause to Tanmoy. Thank you, Tanmoy. Excellent demonstration, excellent. So now we go over to the OT2 where Dr. Surendra Prakash is waiting and Dr. Kumar Saurav is going to be the OT moderator. So over to you, Saurav.